Dr. Burgess is the Assistant Director of the Center for Maternal-Fetal Medicine at Valley Medical Group. She completed her residency training at Columbia Presbyterian Medical Center in obstetrics and gynecology, and then completed a fellowship in maternal and fetal medicine at Columbia Presbyterian, followed by another in patient safety at Virginia Commonwealth University. Dr. Burgess is certified by the American Board of Obstetrics and Gynecology and a certification of special quality in maternal and fetal medicine. Our second speaker is Keri Greenside. Dr. Greenside is a reproductive endocrinologist and infertility specialist with the Valley Hospital Fertility Center. She completed her residency training at New York University Medical Center in obstetrics and gynecology, and then completed a fellowship in reproductive endocrinology and infertility at Montefiore Medical Center. Dr. Greenside is board certified by the American Board of Obstetrics and Gynecology and the Subspecialty Board of Reproductive Endocrinology. So I'd like to turn it over to Dr. Burgess.
So good evening. Thank you for attending. We can go to the next slide. So in the next slide. So this evening, we're going to be talking mostly about single motherhood. A growing number of women, including women of color, are making the decision to conceive and raise children on their own without having a partner. So tonight, we were going to discuss and review some of the resources that are available to support and empower women on this journey, and to just give you an idea of some of the reproductive and fertility options that exist currently. Next slide. So we just like to say that neither Dr. Greenside nor I are receiving any kind of financial incentive from doing this program. We're just out of the sheer goodness of our hearts want to share this information and try to just give as much knowledge and empowerment as possible. So very briefly, I'm Traci Burgess. As Ms. Lucas mentioned, I am the director of the Center for Maternal-Fetal Medicine at the Valley Hospital. So I'm a high-risk specialist or perinatologist, and I am also a single mother by choice.
And I'm Keri Greenside, and I'm a reproductive endocrinologist and infertility specialist at the Valley Hospital. And I'm both a mother and a physician.
So single parenting is actually not as uncommon as some people think. Of the approximately 4.3 million total births in our country, about 1.7 million are to single mothers, and single moms make an active decision to parent alone. What can be difficult when you're trying to find out some of the statistics about this population and how people are doing is there's really not a lot of research on the segment of moms who actually choose to be single parents. You can sometimes find statistics generally on just unwed mothers or unwed parents. It also of note, if you look towards the right, the number of families that have single dads have been also on the increase over time. So that's good to note. And one of my colleagues, and I quickly was reviewing some of these slides, mentioned that our future discussion may include single fathers. So noted. Next slide.
Sorry, technical difficulty. Hold on.
So we're going to talk mostly about, again, single mother becoming a mom. But what I like to always bring up that the important question frequently is, do you want to be pregnant or do you want to parent? Because they really can be separate conversations and discussion. And so as one is thinking about their parenting options, you have to then consider for yourself whether or not adoption is an option, and different conversations frequently with some of the mental health providers that we work with. They may help someone work through or think about this as an option as well.
So our goal at the Fertility Center is definitely to provide access to fertility treatment for everyone. So first thing that we do when a patient is interested in getting pregnant is we have an initial consultation. This is just a talking visit. And we want to meet the patient and we want to know your background, your medical issues, anything that could impact the ability of you to get pregnant or carry a pregnancy. And we want to start, after doing that history, with an initial workup. The workup is relatively basic, and our goal is to just find out what is going to be the ideal way to get our patients pregnant. So we do an initial evaluation of ovarian reserve. That's a fancy term that we use to just talk about egg quantity and quality. And we do that with a combination of blood work and ultrasound. In addition to just getting those results, it's important to know that age does have an impact on our egg quantity and quality and on our ability to get pregnant. With that being said, it's important to note that most of the time in our single moms who are looking to get pregnant, it's common that they haven't yet tried to conceive and they're coming to me to try. And so your egg quantity does not always play such a big role in this setting. It's much more meaningful when we're looking at somebody who has already tried to conceive. When you're just starting out, it doesn't matter what your ovarian reserve is, you're still able to get pregnant. We also want to assess for ovulation. Ovulation is the ability of your egg to be released from the ovary and fertilize. When a patient has regular menstrual cycles, it's likely that they are ovulating. But if there's any concerns about the length of their menstrual cycle, how often they get it, and whether or not they're ovulating, that's something that we are going to assess, because that may impact what type of treatment we choose in the future. Another thing that we like to evaluate ahead of time, and again, the reason that we do all this evaluation ahead of time is because we want to give patients the best chance of whatever treatment we choose at being successful. So we evaluate the uterine cavity and we evaluate to see if the fallopian tubes are open. We also perform some routine preconception testing because we want to maximize the health of our patients prior to pregnancy. So we look at infectious diseases, immunization status, thyroid function, and some routine blood tests. And if anything is an issue, we want to try to treat our patients and maximize them for their success for a healthy pregnancy. We also offer genetic screening, and we do this prior to patients getting pregnant. We offer this to them, and we do this specifically because we're looking for any type of genetic diseases that you may carry. And again, these are not diseases that you have, these are just genetic diseases that you carry. And the reason that we're looking for them is because you are going to most likely be choosing a sperm donor as the next step. And if you do carry a mutation for a particular disease, the risk to your child really only comes into play if you choose a sperm donor that also carries that disease. So if you have that knowledge ahead of time, knowing what diseases you may carry, you can actually choose a sperm donor that does not carry that disorder. And then your child would have a very low risk of having a genetic disorder. The next thing is to consider donor sperm selection. And we provide our patients with a variety of reputable sperm banks to go looking for selecting a sperm donor. And we strongly encourage our patients prior to actually selecting the sperm donor to actually have a consultation with a reproductive psychologist. So the reproductive psychologist consultation, and we can go to the next slide, is very informative. If you're able to, Liz, you could go to the next slide. Thank you. The reproductive psychologist consultation is really informative. They help us think about what are our priorities as a patient, what to think about in terms of that donor's medical history and that donor's family history, and also to think about, do you want to consider a donor who is requesting open versus closed identity? And I want to get into a little bit more of that. So donors can decide that they want to give the child the option to identify that donor when the child turns 18. And it's important to understand that this is only a one-way connection. Only the child can reach out to the donor should they choose to do that. The donor cannot reach out to the child. But it's also important to know it's not a guarantee. The donor needs to keep their contact information up to date with the sperm bank. So that's not always a guarantee, but something to really think about. And when speaking with one of our close reproductive psychologists, she often recommends that patients do consider choosing a donor that is an open identity donor. And the reason is that kids are curious and they might want to pursue this in the future. And if they should wish to pursue this in the future, choosing somebody who at the time of donation chose to be open identity is less likely to reject that child and more be open to meeting that child should the child like to meet them. The reproductive psychologist consultation also deals with disclosure to the child in the future, when to disclose, what language to use, how to maybe talk about this with your family and friends, to think about having a good support system in place, childcare, a will. And there's tons of resources now that are available, both online and in print, that can talk about a lot of these important issues. And we can go to the next slide. So the last thing I want to bring up, and I don't want to get into too much technical detail, is just getting pregnant. This is a graphic here of a uterus, and we can see that next to the uterus, a woman has 2 ovaries and 2 fallopian tubes. I think most of us know that, but just in case, that's okay. A little review of biology is never bad. And in a typical menstrual cycle, a woman will ovulate an egg from one of her ovaries, and it will get released into the fallopian tube. The sperm then travels through the vagina, through the cervix, and meets the egg in the fallopian tube. So what we do is we help patients by putting the sperm inside the uterus through a small, thin catheter. And on the next slide, I'm going to show you another diagram of this. And I want patients to understand that this is, if you can move to the next slide, that's great. This is typically a non-painful procedure. It even is less uncomfortable than a pap smear. A speculum is used so that we can see the cervix, and a thin catheter is inserted into the uterus, and we put the sperm in. The procedure takes literally minutes, and you can go about your day. It does not interfere. The most important thing for us is we want to get this timing right. We want to make sure that your chances of success are excellent with this technique. Are your tubes open? Are you ovulating? Do we have the timing down? What is your ovarian reserve? And if we think that there's any issues with the answer to those questions, then we can move on to a variety of fertility treatments that we offer. And if we can move on to the next slide, I think one other thing that's really important to remember is that it doesn't always happen in the first try, and that there's a word that we use in medicine called fecundability, which is the probability of achieving a pregnancy in a single menstrual cycle. And that's about 25 to 30%. And so it doesn't always happen on the first try, and that's okay. Sometimes we have to give it a couple of tries. And if it still doesn't work after a couple of tries, we can always move on to a variety of fertility treatments. So we never want patients to get frustrated about this. We're here to get to the end game, which of course is a healthy pregnancy.
So similar to what my colleague just ended on, talking about a healthy pregnancy, I want to just touch on a couple of key concepts and not make this too medical, but just to go on, because we want people to achieve whatever success may be for them during pregnancy or at parenting. Just some couple of things to just remember is that preconception care really is very, very important. What I've come to realize is that there's lots of times when we're not as maybe aware of some of our biology and some of the issues that may come and make achieving pregnancy a little bit more difficult as you're kind of contemplating the timing of when one wants to have a child. What I've seen a lot in both my personal and professional life is that many women tend to think about this as an option, even fleeting, when they're approaching more like 35 plus. And there are times when they haven't thought through some of their basic medical issues and are not really aware of pregnancy, high-risk pregnancy, So we want to make sure that as much as possible, just give you some additional information. When you're talking also about pregnancy, and particularly pregnancy in the BIPOC or Black and Indigenous populations of color, we also know that there's some health disparities that exist that play into trying to achieve your most optimal outcome. Next slide. So as a high-risk OB doctor, I'm frequently thinking or talking to patients about the preconception period, a bit of what Dr. Greenside just spoke about, pregnancy, as well as the time period after a pregnancy, because there are things that we can do during this phase. So one shouldn't think of just the first, second, and third trimester of pregnancy. You really need to be prepared and some of the preparation that needs to go into it, because next slide, we may find in some instances, some of us may be more high risk. So what does high risk mean? I sometimes laugh and joke when I talk to patients that as a high risk OB doctor, I can find something high risk in almost everybody. But really, what we try to do as OB and high risk OB doctors is forever risk assess a person and where they are at the time that we meet them. And so we can try to optimize the ultimate outcome. So you can be high risk because of a maternal issue, a maternal medical issue, which could be related to age or weight or blood pressure or something else in the family history. Or you can become high risk for pregnancy related issues that may be, again, something maternal medical like blood pressure, diabetes, but it may also be something unique to pregnancy like having multiple gestation or having a placental problem. So as much as possible, we try to identify, even in that pre-pregnancy period, are there any maternal medical conditions that should be addressed or should be optimized? What medicines you're taking, even things like your mammogram, your baseline cardiac status, so that during a pregnancy, we can optimize and come up with the best plan and individualize it to you. As the population gets heavier, as the population gets older, and having more baseline cardiac issues, we find that this also comes into play sometimes with the ability to get pregnant, and then what may happen in the course of the pregnancy and the timing. So when you're a single mom, particularly if you may not have the support as close or as handy as you're going through these tests pre-pregnancy, during pregnancy, it can add to some of the pressures that you may think about when you're, even if you're not a single mom and you're just a person who hasn't thought about it, and you're approaching pregnancy, to learn early in the course of pregnancy that you may be high risk can sometimes be stressful. So ideally, if anybody has any questions about what that is and what may make you high risk, we can address that in some of the questions. Next slide. Again, as the high risk OB person, my ideal would be to do whatever we can to try to normalize or optimize somebody's outcome. But again, many women will start to approach this thought of, hey, maybe I do want to have a pregnancy at 35, and not necessarily recognizing, as was mentioned before, the likelihood of getting pregnant with your own egg. You see a lot of the celebrities that seem to get pregnant and carry pregnancies without any issues, or have babies without any issues. Sometimes it's surrogate, sometimes it's donor egg. So you have to be careful at what you're looking at in the media. But as we get older, pregnancies tend to be more complicated, and again can be associated with delivering a baby born too soon. So the picture of the little baby in the middle is a baby who was born preterm or premature. So with high risk situations, the likelihood, the possibility of a preterm baby goes up. Similarly, when you are evaluated by my colleague, Dr. Greenseid, and we're working through some of the ways that may get you pregnant, the risk for multiples go up. And so we just consider in general multiples as being a high risk problem. The beauty is that in 2022, with well supervised care by a reproductive endocrinologist, the likelihood of the high order multiple gestations are far lower than what we saw in the past. And that's important, because where it may seem like, great, I'm going to have twins or triplets and I'll just knock this all out at one time, there really are medical issues for both the mom and the baby that go along with that. Next slide. And just very briefly, for the population of women of color, we heard so much in the media these last couple of years about things related to disparities in how women of color tend to have more adverse pregnancy outcomes. So we recognize that that's the case. It's been reported fairly widely through our American College of OBGYN, Society of Maternal-Fetal Medicine, and multiple medical specialties from physicians, patient groups, nursing groups. We are trying to really address some of these issues medically, systemically, to try to normalize or improve some of these outcomes. But we do have things that are in place for women of color and all women to make sure that as they interact and engage with the health system, that they can feel heard and that they're able to try to advocate for themselves and empower themselves, both with the knowledge that they may need and how they communicate that with their healthcare team, so that in a shared decision-making framework, you can have the experience that ideally you want to have as you are moving to have your family. I think at this point, we're just now open for any questions and conversation that you all may have. Ms. Lucas?
I'm just going to stop sharing this. So,
and I'll just maybe just add one thing. So just very briefly, as a single mom by choice, I'm sort of here to kind of just briefly share a little bit of my journey. I had maybe a little bit more information as a high-risk pregnancy specialist because I knew the biology, I understood the timing, I knew what the risks, may be. But it still, was something I had to come to grips with and think about and talk about and plan for. We talked about the reproductive psychologist conversation, and that was really quite beneficial, I think, for my journey, because it was a good person to kind of just sit down and just bat all kinds of different what ifs and to kind of play out some things in terms of how you would approach this or how you would think about that. That coming from a person who's already knowledgeable as opposed to a girlfriend or a buddy or someone else. So that was a very valuable experience. And as we kind of alluded to before, there's a growing population of women who are opting to, parent alone, and there's support groups, and you can make your own little support group as you go. But in general, while it may seem, and maybe perhaps a decade or so ago, it was less common and maybe less well understood by the general population. There are far more people that are accepting of that choice if you're an individual who would like to feel accepted by the general population. So I think that may make many people feel more comfortable, sometimes as well, just knowing that they're not a unicorn. There are lots of us out here, sometimes just in having the conversation, you recognize that, hey, this person's in had a similar journey or similar process.
okay, we do have some questions. The first one is, when would thyroid medicine need to be started for someone with subclinical hypothyroidism?
I can take this. I mean, either way, Tracy. So when we notice that somebody has subclinical hypothyroidism, we want to get them started on treatment right away before we even begin any fertility treatment or any donor sperm inseminations. We want to get their thyroid at a good level before they even get pregnant. And it does need to be monitored pretty closely during the pregnancy as well, because the medication that you take to control it may often need to be increased during the pregnancy, not for any fault of your own. It's just a normal course of the pregnancy that the requirements do go up. And so you may have to keep a real close eye on that level and potentially increase the dose of thyroid medication. It's also really important to not overtreat patients who have thyroid disease or subclinical hypothyroidism. So that's another reason why we do like to monitor so closely.
So frequently you'll have testing done in the first trimester, and whether you're under the supervision of an endocrinologist, your general OB/GYN, your infertility specialist, or your high-risk OB, it's common enough that most will monitor your levels, adjust your medication appropriately. And while there may be some pregnancy-related impact to that, in general, most patients fare well and have good outcomes.
And I know you both had touched on this, but is there a suggested or maximum age women should make the decision to pursue single motherhood?
So in terms of success of getting pregnant, we know that the success rates of getting pregnant do decline as women age. But with that being said, we don't want women to get pregnant until they feel ready to get pregnant and can handle that pregnancy and are in a good place to pursue that decision. So there is no definitive age that is the perfect age. But what I will say is that there is the opportunity now that if a patient knows they're not ready yet, but they're going to want to have a pregnancy, egg freezing, and I see that somebody just did post a question on this, egg freezing is an option to preserve their fertility in case when they do come to that time that they're ready to pursue a pregnancy, their eggs are no longer viable. With that being said, and I'll get to that question in a minute, with that being said, there's definitely higher risks at carrying a pregnancy at advanced maternal ages. And Dr. Burgess can certainly comment more on this. So this is a tough decision, but it's something to think about. It's something to reach out to us even before you might be ready, just to talk about your decision, to talk about whether egg freezing seems like a good idea, or you're probably going to be ready relatively soon and you kind of want to just pursue this. I'm just reading, there was one question that popped up that might be related. If a patient's eggs are frozen prior to starting this pregnancy journey, is there a specific criteria that needs to be met in order to use that patient's frozen eggs? Can you only implant eggs that were frozen by the Valley Health System? Okay, no. At Valley, we can transfer in eggs that were frozen elsewhere, and we're happy to use those eggs that were frozen elsewhere. We do need to get some information about how they were frozen and some testing that might have been done beforehand, but that's not a problem to do. Typically, when we see a patient who does have frozen eggs, we do often use that as their ultimate backup. We don't usually go to that as our first step. We kind of use that as a last resort, and we do attempt to get them pregnant, if it is possible, with eggs that they still have now. If we are unsuccessful or we're unable to do that, then of course we can move to the frozen eggs. And Traci, did you want to add to that?
Yes, I'll add just 2 comments. So one, I think it's really important for women to just contemplate what it is they want to do with their parenting options. Not everybody wants to be a parent. Some know that they want to and are not sure when. And so talking about egg freezing as an option when you want to parent, the fact that single motherhood by choice is an option, I think is important so each person can decide what works best for them, with the backdrop of knowing our individual biology. As it relates to some of the high risk issues, if you are older, again, by coming for either preconception consultation visit or discussion early in the course of pregnancy, we can identify some of those things. Even when you start the pregnancy healthy, if you're 40 plus, there are higher rates of blood pressure issues, higher rates of gestational diabetes in pregnancy. You're more likely to get delivered by cesarean. So there are some other risks, much of which can be managed. And then other things can be individualized for whatever a given person's other medical history may be.
I think that kind of goes into our next question is, do mothers who receive fertility treatments or IVF have higher risk pregnancies? I think you kind of addressed that in that statement.
What I usually say, while the risk may be a little bit higher, it's not dramatically higher than the background risk. So for the majority of people, it's not so high that you would opt out of having pregnancy. There are a few maternal medical issues that may make someone really consider what their options may be, but age alone as a factor, or IVF as alone as a factor, not necessarily.
Okay. What is the most challenging aspect of being a single mother by choice? It's for Dr. Burgess.
I got that one. So there are lots of different challenges, and they sort of have evolved over time. But I think where I was lucky is that I have a support system. So I think having a support system is quite helpful. So while I embarked on this all alone. And really, when I decided to do it, I only shared it with one family member. By the time that I was pregnant and felt comfortable that my pregnancy was ongoing, my tribe embraced my decision and have been there, all the way through. But as a working mom, trying to balance everything, that can be tough. Sometimes it would be nice to feel like that you have another ear to bounce certain decision making off of. Um, so while again you have friends and family, there's some of those nuances that can be a little bit challenging. And then actually, what I thought in the beginning was going to be harder would be talking to my son about some of these different topics about being a single mom, having what our family is, how families are different, the lack of a father or dad. It actually really wasn't as bad as you would expect. From a very young age, I kind of worked it into different conversations, found books, and would talk about it and would talk very openly about it with him. So he now is a tween. He is quite adept at describing to people when they ask, or when a kid may ask a question, well, that doesn't make sense. How can you not have a father? About sort of talking about the process about our family. So what I thought was going to be my biggest challenge actually ended up not being so.
Would you do anything differently?
So the one regret that I kind of do have is that I didn't maybe start the process a little earlier, so that at least for me, the option of a sibling would have I would have felt more comfortable entertaining it. So that's the only thing I would have probably done a little bit differently. Um, I was older than 40 when I actually had my son. And so, in balancing what all the risks may be, I was kind of like, oh, whew, one and done. But in retrospect, sometimes I do wish that I had kind of gone back through the process again. But I don't regret, even when I'm tired and when, he might be in a bad mood, or when I'm trying to juggle something and can't figure out how it all may happen. I don't have a regret about actually making the decision to go on ahead and become, a parent. I think that's been far and away one of the biggest joys and adding things, adding to my, my life overall. So that I don't regret.
Okay, and I think we have one more question, and this is for both of you. What piece of advice do you have for someone who's thinking about becoming a single mother?
I'll start, Tracy, if that's okay.
Okay.
So I actually thought that we should go back to the age discussion a little bit. And I think that, again, people shouldn't undertake this until they are, of course, ready. But I think that the knowledge of the general public about how difficult it is to actually get pregnant at older ages, it's very misleading in the public because of the media and because you're seeing Janet Jackson pregnant at 50 or whoever else and what they're doing. And I think that this is a piece of information that I'm trying to spread to the community all over, is that human reproduction is relatively inefficient and it's not that easy to get pregnant. And so age has a huge impact on this. And we never like to give a cutoff, like you can't get pregnant after this age, but it's true. At 35 is sort of that cutoff of sort of advanced maternal age when a lot of our risks are going to increase. And that is true. But there are many people that make appointments with me at 45 and 46, and they're just now thinking about pregnancy. And I want to be honest that the likelihood of success, really over 42, the likelihood of success declines so dramatically, so dramatically. And Tracy, we both know, I mean, even in the late 30s and early 40s, it's hard, but by those ages, it's really something that we have a lot of difficulty getting a pregnancy with a woman's own eggs at that age. So I'd love to see you earlier. I'd love to be able to talk to you, even if you're not ready. Just to describe the process, get you sort of to meet with a reproductive psychologist and think about all of these decisions so that you could set yourself up for a good time, and not when it's too late.
And, just to piggyback a bit, I will have, I will go to different talks, different community groups. I try frequently actually to talk to college age women, women who are maybe starting their careers, graduate programs, when they're still in their 20s, just to kind of go over this stuff, because you may be in the midst of a booming, great career and focused on that. And then not again thinking about whatever this time may be, particularly when you see all these other celebrities and people having their families. And so just to let them know, or just to remind them in a sense, think about it. Just make sure that this, if you know deep down that you want to be a parent, that you really need to think about what your options would be. And because not everybody has an easy time, or some people are diabetic, or sometimes you're starting and you're overweight, but you want to try to have a baby. Well, when you have a BMI, particularly a BMI that's over 40, that makes it hard to become pregnant spontaneously, or even with a reproductive endocrinologist assistance. So while you're working the career, you can also work your diet and activity program, so you can put yourself now in a better place. So if in 2 years you want to approach pregnancy, you're just in a better place. So, but if you're not thinking about it, if you don't realize it's an issue, then again, both in my personal and professional life, I have seen a lot of disappointment. And as a high-risk OB doctor, it's a terrible feeling when you have a conversation with somebody about the likelihood of them having pregnancy, or getting pregnant, or achieving pregnancy and having a good outcome. That's not a place where I want to be. So that's why I'm always willing to talk about this kind of a topic, to highlight what our options may be, so we can make whatever the best choice may be. So while I wouldn't advocate somebody getting pregnant at a time when they're not ready, right? Because you want to be ready, and whatever ready is, that's an individual thing. It's an important conversation or discussion to have younger than we typically have been having these conversations.
Great. Well, I think those are all of our questions this evening. I'd like to thank both of you for sharing this great information this evening.